Hello, everybody. So I hope that you are weathering the quarantine. Well, I guess not the quarantine, the stay-at-home orders fairly well. Hope you're stocked up on TP and all that kind of good stuff. Gotten plenty of food, watched some good shows. If you've not seen Ozark yet on Netflix, good lord, I cannot recommend that enough. Unbelievably good. That or Schitt's Creek. Oh my god. Talk about binge watching episodes. Good lord. Anyways, um, so tonight, or tonight, yeah, hello. While we kind of cover this here, the chapter 9, we're going to talk about the joints. Right, over the last number of weeks, really, because of the 2 week spring break, it was probably started a month ago. We started talking about the skeletal system, right? We started to look at the different bones of the body. We began looking at some of the different features of the bones, right? Kind of those large projections, right? Remember the acromion process on the scapula, or the greater tubercle on the humerus, right? These different structures on the bones had different purposes, right? Oftentimes it was an attachment point for various muscles and ligaments. And so last week, in the video that you had watched, that's where we went over yes, a decent amount of muscles, right? The muscles of the body. Then we talked about the function of what they do. Now, the reason why those muscles move, the body in a particular way, the reason why your biceps brachii, for instance, moves your or flexes your elbow, right, is because of where it attaches to on the bone, right? It has a certain amount of movement. There's a reason why your shoulder can move in the way that it does. There's a reason why your shoulder can perform circumduction or can perform these big giant circles. There's a reason why your thumb moves in the way that it does. There's a reason why your thumb moves in a way that your other fingers cannot. Right? It has to do with the orientation, the design of the joints in the body. And so depending on where we are in the body, right, depending on what the function needs to be, right, that's going to dictate what sort of movement is carried out, right, as far as in the, down here in the pelvic region, right, right in through here. We're going to look at a joint called the pubic symphysis. Again, that allows a very small amount of movement of, in that joint, very small amount, much different than, let's say, for instance, in the elbow, right? The elbow, there's a huge amount of movement which is allowed and permitted. And again, that has to do with the design of the joint. And the design of the joint is based upon what sort of functionality is needed in that particular area. So one of the first kind of joints, and we're really not going to talk too much about some of these joints in the body. For the bulk of what we're going to discuss, they're called synovial or diarthrodial joints, right? When you think about, really, in large part, any of the joints in the body, they are what are called synovial or diarthrodial joints. The joints that have a large degree of motion, like the fingers, the elbow, the wrist, the knees, the hip, the ankles, the toes, etc. Those are synovial joints, right? Joints that we don't really think about are, for instance, this one here, something called a fibrous or a synarthrosis. Again, the sutures that we discovered that we discussed in the skeletal system. There was the sagittal suture, for instance, if you'll recall. So you're right. Sorry about that. I had to pause for a second. My dog, I don't know, saw her shadow or saw her a squirrel out the window, something. I'm not really sure. Um, Anyways, as I was saying, the sutures, right, in the skull, the sagittal suture between the parietal bones, the suture, the coronal suture, which is between the frontal bone and the parietal bones, right? These kind of zipper-like structures, or these zippering appearing lines in the skull, as well as the facial bones or the cranial bones. They kind of hold these different bones together, right? There is, I mean, for all intents and purposes, there's no movement. They're immobile joints, right? They permit an unbelievably small degree of motion, right? But it's nothing that you would ever be able to actually, you know, for instance, pushing at someone's skull, you wouldn't be able to feel these different bones actually moving. Another idea, or another couple of examples, right, we see here of fibrous or synarthroses. Again, something called the interosseous membrane. There's a few different places where this exists, right, within, right, the leg, between the fibula and the tibia. You can see all on through here, this interosseous membrane. I'm kind of putting these red hash marks through it. That's an interosseous membrane. That membrane is meant to hold the fibula and the tibia together. You see the same thing between the radius and the ulna of the forearm. Now, one other example, right? Something called a gummphosis. Think of the gums, right? The gums are in your mouth. Yeah, the joint by which the teeth insert into, or the joint that's created when the teeth insert into the alveolar process. That is a gummphosis. That's the style or the type of joint which is created. Now, these next joints we're going to talk about are cartilaginous or amphiarthrodial. Right? They have a small degree of movement. Right? Nothing tremendous, nowhere near the amount of synovial joints, which we'll talk about in a second. But when we talk about the ribs, do the ribs have to move? Absolutely. Right? Just take a big deep breath in. Right? As you take a deep breath in, or even as you breathe, your ribs expand. Right? And why that happens is your ribs expand. As that happens, that increases the volume inside of the thoracic cavity, which reduces the pressure, and therefore air rushes into the lungs. Right? So there has to be the ability for the lungs to move some degree, and there is. Right? You can even, you yourself, you can just push on your ribs and you feel that actual moving occur. Right? The pubic symphysis. Right? This guy here. Right? Between the right and left hip bones or pelvic bones, right, is this pubic symphysis. It does move, again, a very small amount. And it has to, as we walk, right, the hip bones, the left hip bone, the right hip bone, and the sacrum. Essentially, as, while we walk, the sacrum stays relatively, stationary. The left and right hip bone, they kind of do this balancing act in the sense that as one hip bone rocks forward, the opposing hip bone rocks backwards and vice versa, depending on the step that you take. It's not a tremendous amount of movement, but there is a small amount of movement which does occur. The other place where you see symphyses is, or are, the intervertebral discs. Right? Remember when we had discussed the vertebrae. We talked about the body of the vertebrae. We talked about the superior articular facets, the spinous processes, all those different structures. Well, in between the vertebrae, right, in between, for instance, the 5th and 6th thoracic vertebrae, there is an intervertebral disc. Right, that intervertebral disc acts like this kind of cushiony sponge. Right, that's an example of a symphysis. Right, it does degree a small amount of movement. Now you don't get confused. You're like, well, man, my spine, I can move a ton, right? I can, like, just if you think about how much you can bend over, forward, or how much you can bend backwards, or how much you can bend side to side, or how much you can rotate your head. When you think about that movement, right, think about the number of vertebrae there are. Right, so each individual vertebrae, or each individual joint, moves a very small amount for you to be able to bend forward, for instance. But each individual joint in the spine moves a very small amount. It's just a cumulative effect, right? Just like whatever. I mean, any amount of money is fine, but let's say if somebody gives you, $1, it's not that many. But then if 20 people give you $1, okay, I get it, it's only $20, but you know what? 20 bucks is 20 bucks. It's just a cumulative effect. Same idea, right? If each joint in the lumbar spine can move, let's say, 10 degrees, right? Then the fact that there's 5 of them, right? That's a total of 50 degrees. So just the idea that even though the spine as a whole can move a great deal, the individual joints are not synovial joints, right? The joints between the intervertebral discs create, that's a symphysis, and again, that's a cartilaginous or an amphiarthrodial joint. Now, here is where we are going to start to look at synovial joints, right? This is just one example of a synovial joint. This is the finger, right? So just look at your finger, doesn't matter which one, and just move it around a fair amount, right? And you can see, like, man, it just moves a lot, right? If you push on your skull, you're not going to really feel much movement at all, right? You're going to feel, if you're like, oh man, I feel the movement, what you're feeling is basically the compression of the soft tissue overlying the skull. Push on your ribs, you can feel them move, right? Do they move a lot? Not really. At most, maybe, I don't know, an inch. Maybe if you really compress them, you can get some more movement out of them. But by and large, they don't move a huge amount. Now, synovial joints, that is their characteristic, right? Look at your finger and just bend it, and then stick it back up straight, and then bend it again, right? Just think of how much movement is actually occurring there. It's a huge amount of movement. There's a huge amount of movement which is occurring there. So a couple of things that we're going to see revolving or that we're going to see in regards to synovial joints. A couple of things we're going to see, right? Articular cartilage. And the articular cartilage, right, that we're going to see right in through here, right here, as well as in through here. Now the whole purpose of the articular cartilage, right? We move a lot. Well, let's back that up. We are supposed to move a lot, right? Bone in and of itself they're very, very hard, right? The surface of bone, I mean, it's smooth, kind of, sort of. Certain spots of it are relatively rough, right? But where we have two bones come together, right? Whether it's the tibia and the femur, whether it's if we're talking about the finger, let's say we talk about the middle phalanx and the distal phalanx, or the proximal phalanx and the middle phalanx, right? That kind of that first knuckle of the finger. Those synovial joints have articular cartilage present, right? That articular cartilage is going to line both ends of the bone, right? And the whole idea is you want two very, very smooth, two very, very kind of non-frictional, soft ends of the bone coming together to coming together to minimize the amount of friction that's going to build up, right? For instance, take a person who, whatever, grandma or grandpa, somebody who gets arthritis. Now, specifically osteoarthritis. There's many different types of arthritis, right? When I say osteoarthritis, yeah, that's like the arthritis we talk about, that as I get older, I get arthritis, that sort of thing. So what actually happens with that is, as we age, and it's not only as we age, let's say if there's been a tremendous amount of injury or damage to a particular joint, right? The cartilage begins to thin out. Well, just think about it. You go out for a jog with shoes that have a very thick sole on them. Oh, it's pretty comfortable. No problem. Then let's imagine you took a pair of hard plastic, or let's say you put on a pair of wooden clogs, right, and then went for a run. Just imagine kind of how jolting each step would be. That's what the articular cartilage prevents, is that kind of jarring, slamming together of the bones. Right? Articular cartilage, again, articular cartilage is specifically made up of hyaline cartilage. It's relatively rigid. I mean, it's definitely spongy in the sense that it kind of can deform a small amount, compress a little bit, and then expand back to its original shape, right? But its purpose is to provide this very smooth surface for the bones to articulate or to move against one another on. Now, a couple other things we see. Because of the amount of movement we see, right, something called the synovial membrane. It's highlighted, it's the red structure. The synovial membrane, or the synovium, that's something that's going to produce synovial fluid, or joint fluid, right? Just like in your car, or your lawnmower, or your dirt bike, or your motorcycle, or your moped, whatever it happens to be. You put oil in your car. You put oil in the engine. Why? Because there are many moving parts. For your car, you want the pistons as they move up and down in the cylinder. You want them to be lubricated. Why? Well, if they're not lubricated, they begin to create heat, which can then begin to break down the engine much more quickly. Same exact idea with these synovial joints. If there's no oil in the joint becomes kind of dried up, and there's nothing which is going to provide any sort of lubrication to this movement. So the synovial membrane begins to, or the synovial membrane, that's the structure which actually produces the synovial fluid. Right? Synovial fluid, this is one of the important things of warming up prior to exercise. It's not so much like, oh, increasing blood flow, that's going to happen. Right? That's going to happen regardless. One of the biggest, if not the most important thing regarding warming up, even as far as like risk of injury and things like that, even that's questionable, right? As far as the research that's on it. But one of the things that we know is that the synovial fluid, as we sit, this stuff becomes very kind of gelatinous, right? Almost like hair gel. Right? Think of like a thickened, well, I was going to say thickened hair gel, but think of like hair gel or Jello. Right? As we begin to utilize and move the joint over the course of a couple of minutes, that's what actually thins out the synovial fluid, so it can then act like a joint lubricant. Same thing with it. Same thing as in the car. Or when you first start your car up, right, that oil takes a couple of minutes for it to begin to warm up and thin out. So the first, let's just imagine, hey, I've jumped right out of bed, or hey, I've been sitting down for 3 hours, and I'm going to jump up and whatever, go off in a dead sprint, or I go to start walking up some stairs. When we're younger, it's not an issue, right? But my God, I laid down on the floor the other day with my kids, and I went to get up, and I don't remember even just a couple of years ago it being this difficult and this painful to get up off of the floor, right? So as we age, right, things begin to break down, tissues begin to break down, synovial fluid begins to, the synovial membrane begins to produce that much less synovial fluid. Over time, right, the synovial membrane begins to break down. Over time, the hyaline cartilage begins to break down. Right? Now, when I say the synovial membrane begins to break down, I'm not talking about, for instance, if somebody has rheumatoid arthritis. That's when there is an autoimmune destruction of the synovial membrane. That is much different than in osteoarthritis. In osteoarthritis, you don't have the destruction of the synovial membrane. Right? You have the thinning out and the destruction of the articular cartilage, absolutely, but you don't have destruction of the synovial membrane. Even if there's not a destruction of the membrane, the amount of fluid it produces definitely decreases. Right? So the fact that as we age, as there's injury to a joint, there's injury to the joint, the cartilage itself begins to thin. As we age, the synovial membrane produces less fluid. That's why things like, man, when we're, 40s, 50s, and beyond, walking upstairs is a little bit more, I'm not going to say painful, but just a little more uncomfortable than it used to be. Right? That's how much stress stairs adds to the knees, for instance. Right? I'm not going to say, oh, don't ever take stairs. Not at all. But one of the most difficult things that as we age, then as far as the older population and the elderly, is going up and down stairs. That's why so many of them live on single floor houses, right? And that's because when we're younger, when the cartilage is thickened, when the synovial membrane is producing sufficient levels of synovial fluid, they can withstand the force applied to the knee through walking up and down stairs. As we get older, as the cartilage thins, as the membrane doesn't produce as much fluid, no, we can't deal with the stairs because we have less kind of integrity of the joint for the reasons I just mentioned. So, some other aspects that we see right here. We talk about the synovial cavity. Yeah, this kind of brown, yellowish orange color, right? That's just the synovial cavity. When the synovial membrane produces the synovial fluid, it simply dumps it into the synovial cavity, right? And again, that fluid just kind of bathes and coats the entire surface of the joint. And again, here we see same thing, just an actual cadaveric model, where you can see, right? It almost looks like kind of as you're looking at this, it almost looks kind of like a pair of lips. Right, you see here this kind of light pink. Right, this is the articular cartilage. Right, that's the articular cartilage that we were talking about. Right, and you can see how, for instance, on this side of the joint, it's a little hard to see, but over here, how the cartilage has significantly thinned out. Right, if you look there, I don't really see much cartilage. That's because it's thinning out. Same thing over here. Right, so that's very normal as we age. Right, this looks, looking at joints, you can certainly tell joints that have issues or joints that have destruction via, for instance, if somebody has rheumatoid arthritis or psoriatic arthritis, the breakdown, the degeneration of the joint looks way different than it does in osteoarthritis. Don't confuse osteoarthritis with osteoporosis. They both affect the bone, but they are very different. So, excuse me. One of the next things, and really for much of the duration of what we're going to talk about, is the synovial joints. And before we get into specific synovial joints, right, like the glenohumeral joint or the femoroacetabular joint, we're just going to look at some of the different motions, some of the different ways the joints can how they can move. So, for instance, the carpals, right? Remember those wrist bones we talked about? Think of like two blocks. I can't believe I'm doing it, but I'm going to try. Think of like two blocks. That's not bad. And then whatever other block it happens to be. You can't be able to see that. I'll take it. Right, so think of the movement, right? These blocks, if you just take two blocks and two bricks and put them together, and just think about how they can move on each other. Well, they can go back and forth, right and left. Since it's 3D motion, you can also go this route. You could also take the bricks and kind of rotate them. Take this brick and kind of rotate it like this as well. Right, so you can kind of pivot it and rotate them on one another. Again, that image is not particularly helpful. So I would definitely grab whatever, cut 2 boxes of Kleenex, or grab two blocks, whatever happens to be, and just put them together and just kind of move those blocks against each other. Right, and just pay attention to how they move and what they are able to do. Those are, again, the motion in which these plane joints, these planar joints, move. Again, those are the joints within the wrist and between the carpal bones. That's what we see there. Right. The fact that we have 8 carpal bones. Right. Remember the scaphoid, lunate, triquetrum, right, pisiform, and then we have trapezium on the thumb, right, trapezoid, capitate, and then the hamate, right, all 8 carpal bones. The reason why we have all 8 carpal bones, I mean, think of what the wrist can do, right? It can, right, you can flex it, or you can bend it, right? As if you were holding your arm out so you were palm down. If you took your fingers and your whole wrist and just let it drop down towards the ground, that's flexion, right? And then extend it backwards, where you take the back of your palm and kind of raise it up towards the ceiling. And then you can take your wrist to perform abduction or adduction. That's if you're holding your hands, your arms down by your side, hands down by your side, and you kind of move your hand in a way that your pinky gets closer to your thighs. That's adduction. Abduction is if you move it the other way, move it out towards the thumb side, so therefore the hand goes further away from the thigh. Again, so the fact that there's 8 carpals, they can cumulatively have a huge amount of movement. Another form of movement that we see now, hyperextension, extension, flexion, right? There are many joints which can perform extension, flexion. Right here, just this one example, we're utilizing the neck. Right, if you just take your neck and take your chin, drop it down towards your chest, that is flexion. If you take the head and bring it back up to neutral, meaning bring it back up so you're looking straight ahead, again, that movement is extension. Right, that movement is extension, and again, that's not only that's not only pertains to the neck. For instance, the elbow. Right, the elbow flexion. If you hold your elbow up straight, right, and you bend your elbow, or if you decrease the joint of the elbow, or the angle of the joint of the elbow, that's flexion. So if your elbow is bent, so your hand's kind of touching your right shoulder, if your right hand's touching your right shoulder, if you then extend it or straighten out your elbow, that is extension. The shoulder. The shoulder's a little bit more kind of, I wouldn't say complicated, but it's a little bit different just because of the position of the shoulder and where it is. But we can see, right, when we take our shoulder, we take our arm and we move it forward so as to put our hands kind of straight out ahead. Right, that is flexion of the shoulder. Extension is if we bring it from, again, instead of being straight out in front of me, as if you're trying to touch the shoulders of the person in front of you in line. Right, bring your shoulders down towards your side. Right, that motion is extension. Right, that's flexion and that's extension of the shoulder. Same idea, right, with the elbow. I just talked about this one a second ago. If I bend the elbow, so therefore I kind of, let's say I'm talking about my right arm. If I bring my right hand up, so I kind of touch my right shoulder, that is flexion of the elbow. If I take my right elbow and I straighten it out, so my hand moves away from my shoulder, that's elbow extension. And same thing with the wrist and the hand, right? As we take the hand, right? So let's say if I were to make let's say we just talked about the digits, right, or your fingers for a second. If you made a fist, right, that direction that the fingers are moving, that's flexion. Right? So now think about if you make a fist, or it doesn't even matter, you don't have to have a fist at this point, but if you take your, if you are looking at your palm, right, and if you keep your forearm still, but take your palm and kind of bend it so it comes closer to your face, or basically bend, if you're looking at your palm, and if you want to take your fingers and point to your face, right, that's flexion of the wrist. Right, the other way, so instead of bending the wrist so your fingers are pointing at your face, straighten the wrist out, that's extension. Again, the hip kind of follows the same thing as the shoulder, right? hip flexion is if I take my foot and I kind of swing it forward as if I'm going to kick a ball, right? That is flexion of the hip, right? Moving the thigh and the lower extremity forward. If I bring it back, so if I bring think of it, the heel of my foot kind of back towards my butt and then back as if I were going to kick the wall behind me, that's extension of the hip. The knee, if I'm going to kick a ball, right, or if let's just do the opposite. Let's start with flexion. If I want to take my heel and kind of touch it up to my butt, right, or if instead of the heel, my calcaneus, right, your heel bone, I want to touch that to my butt or my gluteus maximus. That is knee flexion. That is flexion of the knee. If I then straighten the knee out, so my knee is straight down, or my foot is straight out, that is knee extension, right? So if you're standing straight up, your legs are locked straight, right? Your knee is extended. If you then take, let's say, your left heel and kind of bend the knees so the heel kicks yourself in the butt, that is knee flexion. Now the intervertebral joints, because of the fact that, right, there are 24 plus, right, intervertebral joints, you're able to bend side to side. Right, same thing with the neck, the torso, the lower back. You can actually bend side to side. That's something called lateral flexion. Right, if you simply bent forward, right, along the sagittal plane, that's just merely flexion. Remember, when you do it side to side like this, right, you can see he's bending to the right, his right. That's lateral flexion. Lateral flexion. Abduction, adduction. So when we talk about the body, when we talk about moving for instance here, the limb, the upper extremity, if you just stand up and have your arms at your side, and if you pick your arms up as if you were kind of lifting them up to do like a bird, like say if you're going to pretend like you're flying, right, as you lift your arms up and away from you, that is abduction. Think of abduct, take away. So abduction, abduction. If I then take my hand and add it back to the body, so if I raise the arm, if I raise my arm up to the side, and then that's abduction. If I then add it back to the torso, so think of ADD, adding, adduction. If I then add it back to the body, that is adduction. Same thing with the hand. If I'm standing in anatomic position, right? Remember, feet spread, feet about shoulder width apart, palms, right, you're facing forward, palms are anterior, facing forward. If I take my hand, and if I kind of move my pinky closer to my thigh, that's adduction of the hand. Right? If I do the opposite, if I take my hand and I move it laterally or towards the thumb side, that is abduction of the hand. So just like we saw in the shoulder, right, with the hip joint, if you're standing on 2 feet, as you take one leg, and if you bring it out to the side, that is abduction. If I then take that same limb and bring it back towards, if I take, for instance, if it's my left leg, I've lifted up. If I then take my left leg and bring it back down so it comes closer to my right thigh, that is adduction. And not to belabor the point, same thing with the fingers. Now, one thing that is a little less utilized, far fewer joints in the body can perform this. Right? This is something called circumduction. Circumduction is when you think about making a circle, right, with your shoulder. You can literally make a shoulder, or yeah, with your shoulder you can make a shoulder. Yeah, with your shoulder you can make a circle, right? Just hold your arm out to the side and just think about kind of making these big, large arcs, these big, large circles. You can do the same thing with your hip, right? Just take your leg and just extend it outwards and just make big circles, right? That's something called circumduction, right? Think circumference, around, circumduction, circle, right? So both the shoulder and the glenohumeral joint can perform this. Now, one thing to not get confused by, the hip and the shoulder, they can perform circumduction. They are each one joint. Now with your head, you can say, well, my head I can make a big circle. So isn't that circumduction? I mean, okay, with your head you can make a big circle, but remember, right, there are many joints in the neck which are all performing different motions for you to be able to, form that circle that your head's actually performing. So because of the fact there's so many joints that are involved, it's not actually circumduction because each joint in and of itself is not performing a certain circumduction. Does that make sense? All right, same thing with the wrist. Oh, hell, the wrist, I can make a circle. Well, not really. It's actually a combination of flexion, lateral. It's actually a combination of flexion, abduction, extension, adduction. That's what you're doing. That's not actual true circumduction. Right? Circumduction is performed by ball and socket joints, right, like the glenohumeral joint or the shoulder joint and the femoroacetabular joint, right, or the hip joint. So the atlantoaxial joint, right, or the atlantoaxial, all right. Atlanto is the atlas, so the first cervical vertebrae, and axial, it's the axis, so the first and second cervical vertebrae. There's a joint between the two of them, right? If you remember, right, off of the second cervical vertebrae, off of the axis, there was something called the odontoid process. That was like a big finger, which kind of stuck up and acted like a kind of like a hoop, right? Or the atlas acted like a hoop. Right, take a ring and kind of put it on your finger, or take like a sizable ring, not like an actual finger ring, but think of like a little hoop, right? Something circular like that, or a big like hoop earring, and kind of just like swirl around your finger. That's kind of the motion that the atlantoaxial joint achieves. It's much more stable than that. But my whole point of what I'm getting at, right, is there's a huge amount of rotation which occurs between your atlas and your axis in the atlantoaxial joint, right? 50%, if you just take your head, look over your left shoulder, take your head, and then from the left shoulder, look all the way over your right shoulder. 50% of that movement came from this one joint. 50%. Whereas this is a very specialized joint because that is a tremendous amount of movement just to come from one particular joint, especially a spinal joint. Right? 50% comes from the atlantoaxial joint. Every other joint in the, right, from C2 all the way down to C7, in that, right, from C2 to C7, they cumulatively only add 50% of the rotation. Right? Cumulatively, they achieve 50%. This one joint, the atlantoaxial joint, that in and of itself achieves 50% of rotation of the cervical spine. So more on rotation, right? Excuse me. Lateral rotation and medial rotation. This is, again, when we look at the limbs. For instance, if you were to imagine if you were kind of sitting down, having your kind of elbows tucked into your side with your kind of hands out in front of you. Right. If you were to take your hand and kind of move it let's say here from your elbow, and kind of move it in this way. That is medial rotation. If from here I take it and I rotate it laterally, that's lateral rotation. Now you can also call this lateral rotation external rotation, or you can call medial rotation internal rotation. Choice is yours. Neither's more correct. Right, so whichever one you want to call it. Again, medial rotation, lateral rotation. You also can see that in the hip joint or the femoral acetabular joint. If I'm standing up, if I take the foot and I kind of turn it outwards, so my toes are pointing outwards, kind of like a duck. Right. Or I guess it would be a penguin. I guess it would be a penguin waddle. I guess it would be, right? Taking the feet and pointing it outwards, right? That's external or lateral rotation of the hip. If I take my toes and kind of turn them inwards, I think that's colloquially they call it duck walk, I think. Right? Take my toes and turn them inwards, right? That is medial rotation or internal rotation of the hip. Again, same thing right here. Right? She's might be a little deceptive, but yeah, she's got some, man, that's some wicked medial rotation. All right. Yeah, okay. All right, so again, the foot turning inwards, that's medial rotation. The foot turning outwards, that's lateral rotation. Certain joints, certain bones can elevate and depress, or they can rise up and pull down. Right? For instance, the mandible. The mandible can elevate and depress. Yeah, when you chew food, when you talk, it's just constant elevation and depression. Just constant. Right? As you close your mouth, that's elevation of the mandible. As you open your mouth, that's depression of the mandible. Right? And the same thing can happen, for instance, the shoulder. We talk about the scapula, right? The trapezius muscle, the levator scapulae, right? Attaching throughout the cervical spine and then down to the root of the scapula. The levator scapulae elevates the scapula, raises it up, right? Think about shrugging your shoulders. When you're doing that, what are you doing? Oh, you're elevating the scapula. Right? Depression, right? The trapezius, primarily. Right? If I take my shoulders and kind of pull them downwards towards my butt, that's depression of the scapula. So again, it's not only the TMJ or the temporomandibular joint which can achieve this. Protraction and retraction. Right? Same thing here. Right? If I take my chin and I kind of stick it outwards, right? That's something called protraction. In the same token, if I take my mandible and I kind of almost like attempt to pull it backwards to kind of give myself like a double chin, that sort of thing, right? That's something called retraction. A little better example, a little bit easier, is the shoulder. If I take my shoulder and I kind of think of it this way, if I take my shoulders and roll them in as much as possible, kind of roll them in and forward, that's protraction of the scapula. If I take my shoulders or my scapula and I pull them back and together, right, that's retraction, almost like I'm trying to stick my chest out, right? What you're doing is actually retracting the scapula when you do that. Here, inversion, eversion, right? Eversion, you can see it when you actually kind of turn the ankle outwards. Inversion is when you turn the ankle inwards. You can see how much more inversion we're actually able to achieve, right? A pretty significant amount more, right? One of the things that has to do with the malleoli, both the lateral malleolus and the medial malleolus. Right? Remember those are the ankle bumps. Right, if it's on your ankle, you're like, oh man, they got tumors. Well, no, those are normal bumps. They're supposed to be there, right? The one on the inside is the medial malleolus. The one on the outside, that's the lateral malleolus. Right. One of the things they do is help to stabilize the ankle. Right. The lateral malleolus is located a bit further inferior word, hence the reason why eversion, or turning out of your ankle, you just can't do anywhere near as much of it. Inversion, you can do a much greater amount. So one of the things that corresponds is because of the increased movement or function of inversion that the ankle can perform, there's a significantly greater amount of inversion sprains. It's not the only reason why, right? Just kind of cutting and just different sporting events and activities just require a greater amount of, apply greater amounts of force in the kind of that inversion plane, if you will. But one of the things is because of the fact that the ankle does move so much more in inversion, it does put it in a greater susceptibility to injury, right? Remember how I've mentioned before, the glenohumeral joint, right? The shoulder joint moves a tremendous amount. So because of that, it's already at an increased likelihood of being injured. Right? Certain joints which don't move, right? I've never heard of anybody injuring a sutural joint, right? You seldom ever hear of anybody injuring a pubic symphysis. Now, can that happen? Sure. Or that can happen. Right? Not very often. Right? Somebody injuring their, right, well, let's back up. I was going to say injuring their intervertebral disc. Herniations, yes, but as far as like a spraining of the pubic symphysis or like a straining or a dislocation or something like that, those are things that you don't see because of the fact that those joints do not move. They move a very small amount. So because they move such a small amount, they're incredibly stable. Those joints which move more so, like the ankle, like the shoulder, right, like the hip, there's just a much greater degree of injury to them. So the ankle, dorsiflexion and plantar flexion. If I take my foot, and if I take my toes and kind of raise them up towards the ceiling, that's something called dorsiflexion. That's something called dorsiflexion. If I then take my toes and kind of point them down towards the floor, that's something called plantar flexion. That's something called plantar flexion. Now, and I haven't been covering them again now because I covered it during the muscular presentation last week. But as I'm doing these different motions, right, think about the muscles which are primarily causing these, functions to form. For instance, with plantar flexion, right? Last week I mentioned, your gastrocnemius and your soleus muscle. They are what propel, cause you to go kind of up on the balls of your feet, right? So that is plantar flexion, dorsiflexion. Again, predominantly tibialis anterior. Right? So be thinking about the muscles which actually cause this movement to occur. Supination and pronation. If I'm holding a bowl of soup, just imagine yourself grabbing a bowl of soup, holding it in one hand. Right? Imagine grabbing that bowl from the under. Imagine the soup has cooled off. Imagine the soup is not scalding hot. Remember, let's imagine it's gazpacho, so it's cold soup, right? Which if you like gazpacho, more power to you. Whoa, man. Anyways, imagine it's some cold cucumber soup. That's good stuff. Having the bowl in your hand, right? Think about it. Your palm is facing upwards. You're holding the soup. Awesome. If you then take that bowl, grab a hold of it tightly, and then spin it over so you're pouring out the soup. That is if you're pouring it out, that's pronation. The actual movement to going from palm up to palm down. That is pronation. Supination is if you go from basically, palm down, and if I flip it over so I can then put more soup in the bowl, right? That's supination, the actual movement from palm being face down to moving to palm up. That's supination. Now you can see the radioulnar joint. Yeah, the radioulnar joint. Right? That's the actual joint which allows this movement to occur. Imagine taking two sticks, or actually you even just take your left arm and your right arm. Kind of take your elbows and tuck them into your side with your hands and forearm kind of directed out in front of you. But again, your elbows are tucked into your side. If we just take your left arm. Actually, let's back up. Let's imagine my my left arm is my left forearm. Let's imagine that's my radius, and let's imagine my right forearm is the ulna. I'm keeping my right forearm stationary. I'm not moving it at all. If I take my left forearm and fold it over top of the left forearm, that is pronate. That's the movement that would cause pronation of the left arm, of the left forearm. Right? Because what actually happens in pronation and supination, it's just simply movement of the radius. The ulna does not move at all in pronation and supination, right? It can't. Remember the ulna, it was like this, the top part of the ulna had this C shape or this U shape, act like a hook, which hooked right onto the trochlea of the humerus. So the ulna in and of itself cannot rotate, it cannot pronate, it cannot supinate, it doesn't do any of that motion at all. Right? It is purely motion of the radius which achieves supination and pronation. Now, something called opposition. Right? This is what makes us different from the apes out there. Right? Only thing on this earth that we know of that can perform opposition, and that's simply where you take each finger and then attach it to your thumb or oppose it to the thumb. Opposition. Yeah, so take that, gorillas. Maybe bigger and stronger, but you can't do that. You can't do the. Like I said, I don't really know the Boy Scout sign. Maybe I don't know if you oppose the Boy Scout sign, but whatever it is, right? We can do that. Right. So next time you see like a monkey or something, like you can't do that. So, anyways, here, right? We've mentioned a couple of these before. We're just going to kind of go into the different types before we then get into the actual specific synovial joints. But these plane joints, right? I pointed this out before, I don't know, probably half hour ago, 20 minutes ago. Between the carpals was the example I'd used then. You also see it here in the tarsals or these ankle joints. Right? These are plane joints. This is when I talked about taking two blocks and kind of sticking them together. Or not sticking them together. Take two blocks and stack them on each other. Think about the movement that those blocks can do. They can rotate, or they can pivot around each other. They can slide back and forth, right? Take something, take two boxes of tissues and put them together and then move them around each other. Right, like slide those two surfaces back and forth, rotate them around. That's the movement which can be achieved in these plane joints. Hinge joints literally act just like a hinge of a door. Right, hinge of a door only permits that door to move so far in one direction and so far in the opposite direction. Right, it moves around that one hinge. Same exact thing inside of the body. Right, the elbow, right, is a. So as I was saying, sorry for the hiccup. I had to pause for a moment. My dog started flipping out yet again. As I was saying, with the elbow, right, it's a very kind of stable. Yeah, people generally don't injure their elbows all that much because when you think about the movement of the elbow, all right, it can flex and extend. That's it. Much different than the knee, for instance. The knee is another example of a hinge joint. However, the knee structurally is designed much different than. Structurally, the knee is much different than a hinge joint. But because of the number of ligaments and the amount of soft tissue, the knee functions like a hinge joint. When we get to the knee in a number of slides, we're going to look at the different ligaments and the soft tissue which is present to kind of ensure that the knee does function like a hinge. Another type of joint that we've been talking about, again, a pivot joint. Right? This is, for instance, when we talked about pronation and supination just a minute ago. Right? When I had mentioned it's purely movement of the radius. Right? The radius basically folds over top of the ulna. The reason why that can be performed, and the reason why that can happen, is because the joint between that proximal radioulnar joint, the reason that the radius can rotate or pivot in place is because of what's called a pivot joint, or the fact that that joint which is formed is something called a pivot joint. Take your foot, plant it to the floor like in basketball. Right, let's say you're dribbling, you pick up your dribble. You can then take your foot and you can pivot, right, around that connection point. Right. Obviously, in basketball, you can do a 360. You can spin around 100 times. That obviously you can't do through a pivot joint inside of the body, but that is the motion, just like pivoting. If you pivot, let's say, one direction 30 degrees, and then pivot the other direction 30 degrees, right? That's the amount, within normalcy, within the anatomic limits, right? These pivot joints do exactly that. They pivot. Right. Now the condyloid joint, right, between the radius and the scaphoid. Right. You can see, right, a couple of the carpal bones are condyloid joints as well, right? But they're just like with plane joints, right? Even pivot joints, condyloid joints, there's really not a huge number of them. Right? These biaxial movement, meaning think of like the fact that this can shift right and left, the fact that it can rotate forwards and backwards. Right? We say biaxial. So along the along axis is one, bi meaning two, is it has two different planes of motion. Right? We're going to look at a joint similar to that here called a saddle joint. Relatively similar, but the fact that it is a saddle joint, it too is biaxial. You see right here. But the way it's designed, it can move in a different plane or different axes. Right? Think of what we call a saddle joint. Think of like a horse saddle. Right? Again, this kind of horse, I guess an upside down horse saddle. I guess that would be, excuse me. Right, but right here. Right, when this fits into this groove, just think about what you can do. You can pivot, you can rock, you can slide, you can do a huge number of motions with, get these off of there. You can do a huge number of motions. Right, because again, as this piece here is inside of this groove, again, this groove would go all the way around, right? But because of that, that's what gives the thumb a huge amount of motion, right? A massive amount of motion. A ball and socket joint, right? We see between the head of the femur and the acetabulum, the femoroacetabular joint, the femoro being the femur, acetabulum here on the hip bone and the pelvic bone, they together can perform triaxial motion, meaning along three axes, which is why they can, flexion, extension, adduction, that's why they can perform circumduction, right? That big long circle, right? Again, ball and socket joints can achieve that, meaning the glenohumeral joint as well as the femoroacetabular joint. Okay. As I mentioned before, right, we just look at the size of, right, the acetabulum, right, the depth of it, how deep the socket is. It's enormous. Right, the fact that the acetabulum is so deep, that in and of itself gives the hip a tremendous amount of strength. Right, and that just makes sense, right? Your hip joints have to support your entire torso, your entire upper body, right, all the weight that it carries. Now here's where we're going to start to get into some of the more specific synovial joints of the body. Right, this first one we're going to start with, we're going to kind of go from top down, if you will. Here, right, this overlies where we're going to start to discuss the temporomandibular joint. And from here, we can see, right, just look at the proximity, right? Here is the external auditory canal. Again, that's where you stick the Q-tip. I know we're not supposed to, but man, I don't know. It just feels so good, and it just fits perfectly. Anyways, The external acoustic meatus, right, or the external auditory canal right here, just the proximity, right, from the ear to the TMJ. TMJ being here, ear being here. I mean, they're within half of an inch of each other. Right. This is why people very commonly have difficulty differentiating, is this ear pain I'm having or temporomandibular joint pain that I'm having. But you can see there's a number of structures and ligaments, right? This structure here, right? This is zygomatic process of the temporal bone, right? That kind of cheekbone. Well, cheekbone's more so up in here, but kind of the bridge that extends backwards towards the temporal bone. So as we kind of look through here, right, as I mentioned, the zygomatic process of a temporal bone, we're attaching along this structure right here. We see this, something called the lateral ligament. Right? There's going to be a number of different ligaments which are going to support the temporomandibular joint. Now, there's many ligaments which are going to support, the huge number of synovial joints. Because remember, the ligaments are essentially what permit a certain amount of movement in the amount that the joint can actually move, right? When somebody sprains an ankle, for instance, right, what actually happens is you actually have a stretching out of the ligaments, right? Think of putty, right? Ligaments are not like a rubber band. Rubber bands you can stretch, and once you let them go, they snap back to their normal shape and size. Ligaments don't do that. Ligaments they're like putty or like Play-Doh. Right? If you were to grab a thing of putty and stretch it out, guess what? It stays stretched out. It doesn't recoil back to its normal original position. Right? That's why, again, people, kind of the greatest greatest indicator of whether or not somebody's going to, suffer an ankle sprain is if they've already had one. Right? And the reason why that is because the ligaments which are there that are meant to stabilize the ankle, for instance, if they've been overly stretched, or if they've been sprained. Right? There's different grading scales. There's a grading scale, grade 1, 2, and 3. We're not going to go into that. But depending on how much damage has occurred to the ligaments, that ultimately is going to dictate how well and how stable the joint is going forward. So here are a couple of just other ligaments. We're not going to really go, these ones here, I don't really care that you memorize kind of where they are very much. But one of the things to kind of pay attention to, right, the stylomandibular ligament, the sphenomandibular ligament, right, the sphenoid bone, the styloid process of a temporal bone, right. There's a number of different ligaments that, attach to these different structures that we talked about. So there weren't just random structures that we mentioned. There weren't just random structures that we learned, right? Even the styloglossus, which was a muscle that we pointed out. That was a muscle that regulated or helped with the movement of the tongue. That was a muscle which attached to the styloid process. So just like we saw in the finger joint from the 40 minutes ago or so, being a synovial joint, right, the temporomandibular joint has a synovial cavity. Right. This bony structure here, if you'll recall, is the mandibular fossa. Right, mandibular fossa. This bony structure here, it's already labeled. I actually didn't need to point it out. The condylar process of the mandible. This right here. Right, this right here. As these two structures come together, that's what's going to form the temporomandibular joint. Temple, mandibular, mandible. Right, so again, temporomandibular joint. And throughout, you can see superior, inferior compartment. That part I don't so much care about. But the articular disc, the TMJ is a little bit different in its composition than some synovial joints. We see an articular disc or a triarticular disc. when people, for instance, man, when I chew, my jaw kind of clicks and cracks. That's not really painful, but just like kind of just crunk, clicks. Or basically what that emanates from is the movement of this disc and how it compresses, and the fact that if there's any sort of kind of movement or flapping of this articular disc, it kind of produces that clicking, cracking, popping sound. Again, that in and of itself doesn't necessarily mean there's a problem. It just means there could potentially be a problem, right? So again, on both sides, remember, think about it. There's not just there's not just one articular disc, right? For the mandible, there's two, right? And the mandible is one bone, right? The jawbone, that's one bone. You can't move one TMJ and not the other. It's not possible. The elbow, hell, I can flex my left elbow, and that doesn't in any way, shape, or form impact my right. However, if I, let's say, open my mouth, if I move my left TMJ, that has to also move the right TMJ. It has no choice, right? Because the mandible is one particular bone. Right, so this is why, same thing with, right, very typically, commonly people talk about, I've got TMJ, and everybody talks, everybody has a TMJ, everybody has two of them, right? But generally, if it's painful, temporomandibular joint syndrome or something like that, just think of the number of times in the course of a day we move our TMJ. Astronomical, from when we just chew to when we talk, even just, sitting, right, just breathing. Our TMJ moves a huge amount. This here we're going to shift into the glenohumeral joint. Now, there are a number of things that we are going to take a look at here. Right, some of the bony structure. All right, bony structure that we're going to look at here. All right, here's the coracoid process right in through here. Right, you get the acromion process right is up in here. Can't really see it terribly well because of all the ligaments which attach to it. Here's the clavicle, and where that's going to extend, or that's going to travel medially to unite with the sternum. Let's see if I can erase these things. Hey, there we go. So some of the ligaments, right? The trapezoid ligament, the conoid ligament. If somebody has ruptured, or if somebody has let's say a shoulder separation, right? If they've separated their shoulder, what that means is they've actually separated their AC joint, their acromioclavicular joint. That acromioclavicular joint, that's when the clavicle and the acromion process unite, right? And that joint that they form, that's the acromioclavicular joint. So any sort of, for instance, like in football, hockey especially, very common, anything where you kind of drop the shoulder and drive a force into it. So let's say in hockey, if you were going to drive somebody into the boards, you drop the shoulder and then drive, or even if somebody drives you into the boards, you lead with your shoulder to protect your head and your torso. So when that happens, you drop the shoulder drives into the boards, and it puts a huge amount of stress, right? As that happens, the shoulder is pushed down this way. Well, what happens is all these ligaments become overly stretched in this direction, overly stretched in this direction, overly stretched in this direction, and what happens? Depending on the severity of it, they can tear. And when they tear, that's what is, again, the AC joint separation. There's different grades depending on the severity of it, but it's where there's actual damage to these ligaments in through here. A couple other things we didn't see when we looked at the TMJ, or the temporomandibular joint. We didn't see this thing here, this subacromial, subscapular bursa up here, the subacromial bursa. We didn't see those. Right? I mentioned before how within the synovial joints, they have to move a huge amount. So because of that, there has to be this joint lubricant, this synovial fluid, in order to lubricate the joint to permit that much movement so we don't increase the amount of damage to the joint. Overlying the joint, there's a huge amount of ligaments. There's a huge amount of tendons. There's a huge amount of muscles and ligaments that all move in conjunction with one another. Right? As one muscle moves, all the rest of the muscles, all the different tendons, the ligaments, they all move in some way, shape, or form. So there has to be something present to produce this same idea as synovial fluid. There has to be something present in order to kind of inhibit any sort of adhesion or any sort of kind of sticking together of the tendons and of the ligaments which surround the joints. Right? Think about it. People who, I'm not going to say athletes, but if you've ever had like a subacromial bursitis, or if you've ever heard of somebody who has bursitis, right? Bursitis is, again, itis, irritation, bursitis. Yeah, there's irritation, inflammation of the bursa. So if you have too much movement, and it's not just simply too much movement which causes irritation. If there is some sort of movement imbalance, if there's already some sort of degree of injury to the joint, that predisposes you to develop bursitis, for instance, right? Because as the joint moves around, if it's moving in a fashion that it shouldn't, right, that can cause the bursa to become irritated, and that can become immensely painful. Right, the whole purpose of the subacromial bursa, again, is to produce this synovial fluid, but outside of the joint, to prevent the tendons, to prevent the ligaments from, essentially adhering, rubbing up against each other, causing friction, causing irritation, causing inflammation. That's the bursa in general, whichever one it happens to be. It's there to prevent the buildup of friction, heat, inflammation, etc. Some other structures, right? You can see kind of where the subacromial bursa is, right? It lies just tucked up underneath, right, the acromion process of the scapula, hence subacromial process. But something else that we see inside of the glenohumeral joint is something called the glenoid labrum. Again, another way to solidify or to stabilize the shoulder. Remember, the shoulder itself, because of how much it can actually move, it is already going to be at an increased risk of injury. Right? Think of it. There has to be some sort of give and take. Right? For instance, if a joint is going to move a greater amount, it has to if a joint wants to function more, it has to risk some stabilization. Right? The elbow, very stable joint. Doesn't move a lot. I mean, I guess it moves in one plane, that's it. Right? I can flex and extend, that's it. The shoulder is a ball and socket. It can move in 3 different planes, 3 different axes. That's a huge amount of motion. So because of that, there has to be increased ways to stabilize the particular joint. Right? And again, that's the other part of the, specifically the glenoid labrum, is it helps to keep the humeral head within, or keep it in contact with the glenoid cavity, or the glenoid fossa. Remember, think about how shallow the glenoid fossa was on the scapula. Immensely shallow. Right? It was like almost like a tea saucer. Right? Not sure. I don't even know I don't even own a tea saucer. I have no idea why I utilize that. Right? But just think of, if in your hand, do you make a cup? If you're going to hold water in your hand, how you kind of cup your palm. That's like the depth of the glenoid fossa. Nowhere near the depth of the acetabulum of the hip joint. So we have to have something else to stabilize the humeral head while it's in the glenoid fossa. All right, and just like we saw in the TMJ, just like we saw with the previous joint that we covered, we also see, again, this articular capsule, or this joint capsule, right? Lining the humeral head, we also see this articular cartilage. Lining the glenoid cavity, again, lining the glenoid cavity is also going to have articular cartilage. Right? Remember, articular cartilage, that is hyaline cartilage. Speaking of that cartilage, you can see that right all up and through here. Make it blue here. All up and through here. Right. All up and through here. Right. It's lining with articular cartilage to make sure there's this very smooth, very frictionless force, very frictionless surface, which is coming into contact, which are coming into contact to form this glenohumeral joint. Right? The synovial membrane. Right, you can see the synovial membrane. This thin red line all the way down it. Oops, yep, that was awful. Right, but this thin red line we see all the way down through here. Right, that's what's there to produce the synovial fluid, or the synovial fluid. Remember, the synovial membrane is also called the synovium. Right, so don't forget that also shares a name. Here, great image of, again, the acromioclavicular joint. Right, the acromioclavicular joint. Right here is that acromioclavicular joint. Right, this is a joint I'd mentioned if somebody has, let's say, a AC joint separation or something like that, or a shoulder separation. Right, this is a joint that we're talking about right there. Again, actual cadaveric image, right? Articular cartilage, again, we see that here. We see that all up and through here. Now, one thing to keep in mind, or how I'd mentioned before, and there wasn't an image, but here there is. Just look at the shallowness. Yeah. Look how shallow this glenoid fossa is. It's very shallow, right? It's not much more, literally, if you're just with one palm, kind of cup that one palm so you can hold water in it, right? That's a very shallow structure. So because of how shallow this is, again, that's why we have all the increased numbers of ligaments, all the glenoid labrum, all these increased structures to ensure that the glenoid, or that the humeral head stays in the glenoid fossa. And this white part through here. When I mentioned people who are elderly, people, or not even just elderly, had a significant shoulder injury, the cartilage through here, this is going to thin out dramatically as we age or as there's injury. Here's a pretty normal thickness. Right here it starts to thin out. You can see how right through here starts to thin out a little bit. Right. But imagine how, right, as this thins out, and I say it thins out, yeah, eventually from this thickness, it'll go from kind of this thickness here to where this part over here, we see how thin this is. Eventually, this all through here will have that same thickness, or that same thinness, I guess, right? And as it produces that same degree of thinning out, it has a decreased ability to kind of be frictionless, to provide this kind of cushiony sponginess to the actual joint. So we start to have, people kind of colloquially call, oh, I got bone on bone. Yeah, when you have both ends of the bone together without the presence of that cartilage, that's where it can become immensely painful. Now here's where we're going to look at the elbow. Right. Same thing with the elbow. As I mentioned with the shoulder, right, the number of different muscles, ligaments, the amount of movement, just like we saw in the shoulder, right, there was a subacromial bursa, there's some scapular bursa. Here in the elbow, we're going to see the olecranon bursa. Right, same function, just different part of the body. Right, the subarachnoid bursa, again, is going to produce that synovial fluid to help lubricate the ligaments, tendons outside of the joint. Right. With a number of ligaments, right, tendons of the biceps brachii, right, this is a tendon attaching to the radial tuberosity. That would go up, and that muscle would attach itself along the humerus, right, all up and through here, right. Or I'm sorry, that's the brachialis. The biceps brachii would extend up and attach to the glenoid fossa, the supraglenoid tubercle, as well as the coracoid process on the scapula. Right. What's some other structures, other ligaments? An annular ligament of the radius. Yeah, the annular ligament of the radius. That's the ligament which is going to anchor the radial head to the radial notch on the ulna. Right? That's what's going to perform that pivot joint. Remember how I mentioned in pronation and supination, you actually have pivoting of the radius. This is the ligament which helps hold that radial head into the radial notch on the ulna. Again, same idea, just kind of the opposite side, right? Olecranon bursa here, right? You still see the annular ligament. This is merely just a lateral view, whereas the previous image or previous slide was of a medial view. Here is where we're going to look at the hip, right? The femoral-acetabular joint. Now, the femoral-acetabular joint, right here, we had to remove the rectus femoris muscle. Remember, that's the kind of the middle, or kind of the, I don't want to say the meat, but the muscle of the quadriceps femoris, which runs down in between the vastus medialis and the vastus lateralis. To see that, we had to get that muscle out of the way. That's why you see just this little dangly piece here that's been reflected. So the iliofemoral ligament, ilium, femoral, femur, yeah, all along there's this structure here, right? This intertrochanteric line, right? This the arcuate line, some different structures on the femur, which we didn't talk about in our skeletal system presentations, but this is a significant muscle which is going to help anchor and connect the femur to that of the ilium, right? That's the iliofemoral ligament. Same idea, the pubofemoral ligament. Well, pubofemoral, femoral, femur, pubo, to the pubic bone, right? So that's the one thing about ligaments. They generally, sometimes, right, they're named, kind of this outlandish name, but generally they are some sort of combination of the bone they attach to, or the structure they attach to, or sometimes, for instance, the trapezoid ligament. It's just simply named that because it has the appearance of a trapezoid, right? Same thing with conoid. There's it's kind of cone-shaped. So there's a number of different kind of rhymes and reasons as to why the ligaments are named what they are. Generally, it's much more simplistic than what some of the muscles have been named. Again, posterior view, right? Just like we saw before, right? From the anterior view, we saw the pubofemoral, we saw the iliofemoral. If we want to see the ischiofemoral, the ischium, remember the ischium, that's that kind of the sit-down bone, right? If you're sitting on a chair right now, the bone that you're sitting on, or the part of the hip bone you're sitting on, is the ischium. All right, so this ligament, which attaches to the ischium in through here, and it extends out attached to the femur, is the ischiofemoral ligament. The ischiofemoral ligament. Now here's where we get to some of the more interesting stuff. Not that the ligaments weren't interesting, but where we can start to see kind of inside of the joint. And that's one of the things with the hip joint. Excuse me. Think of how much stress, right, and weight and force that the hip joint itself has to be able to withstand. Right. The shoulder, I mean, as you're standing there, the shoulder doesn't really have any force being applied to it. If anything, just with gravity is kind of pulling your arm down out of the socket. So if anything, it's almost like a decompressive or a distractive force. Your hip is never exposed to that. Your hip, unless somebody like grabs a hold of your leg and like pulls on it, nothing ever kind of takes the weight out of the hip. If you're laying down, okay. But if you're standing, all the weight of your upper body is just pushing down directly on the top portion of the hip, right, or this femoral head. Now, when we look kind of all in through here, right, we see all of this spongy bone, all that spongy bone in through there. Now remember, because of how the bone is designed, because of the spongy bone, even though the weight of your body is pushing down right here on the femoral head, because that's happening, the amount of, kind of where the stress biomechanics wise, where the greatest, amount of stress should be bored is right kind of here through here on the femoral neck. Therefore, you would think it would be an increased risk of fracture. But because of the spongy bone and the ability of the spongy bone to disperse the weight, what actually happens is the force of the torso is actually spread out throughout the femur, all the way down and along the diaphysis. The reason that can happen is because of the spongy bone, and that's, again, that is the purpose to the spongy bone. Sure, to give it a lower, the bone, the skeletal system, to give it a lower weight, but really much more to do with the ability to kind of transfer those forces. Just like we saw before, right? All the articular cartilage, all up and through here. Articular cartilage, all up and through here. Right. The synovial membrane, right, all up and through here. Synovial membrane, synovial membrane, synovial membrane. Right. I'll stop drawing lines. I just find it therapeutic sometimes. But the same thing, just like before, right? With these synovial joints, you're going to have the synovial membrane or the synovium. That synovium is going to produce the synovial fluid, right? That synovial fluid then enters into the synovial cavity. A couple other things. Just like we saw in the shoulder, we saw the glenoid labrum. In the femoroacetabular joint, we see the glenoid. We see the acetabular labrum. The acetabular labrum, right? Now, it's in a much greater amount than just here. It would extend like kind of all the way across and surround the femoral head. However, just because of the way that this is cut, you can only see a very small amount of it. But the same idea, the acetabular labrum is going to help hold the femoral head into the acetabulum. Right. Something else that's going to help with that is this structure right here, the ligament of the head of the femur. Man, that sounds kind of ridiculously named. It's because it is, right? As I mentioned, right, sometimes things in the body are named for I have no idea why, and other times you're like, really? That's what they came up with? Ligament of head of the femur. Okay, let's go with that. And this comes out of something. Remember, the fovea capitis, if you remember, that's a structure. If we look at the femoral head, right? If you're kind of staring at the femoral head, there was almost looks like kind of like a bite, or somebody kind of scooped something out of it, right? That is the fovea capitis. That's the fovea capitis. That's where the ligament of the head of the femur actually inserts into. There's also a blood vessel, right, which enters into the femur there as well. Cardiovascular system, we'll talk about that. Right, but the fovea capitis, that's where the ligament of the head of the femur actually inserts into. So continuing downward, right, we see the knee, right, the knee joint. So what I had mentioned, right, the knee by design really shouldn't function much like a hinge, but it does, and it has to do with the ligaments that are present. So at the distal end of the femur, if you remember, it kind of almost has like this dew claw appearance. There was the lateral condyle, there was the medial condyle, and they are entirely lined with hyaline cartilage or articular cartilage. Right? And the reason why that is because of the fact that, well, our knee does move a pretty significant amount, right? You can extend it, you can straighten it out 180 degrees, and then you can take that, your heel, and essentially kick yourself in the butt. So the knee can go through quite a substantial amount of movement. Right. A couple of things, because keep in mind that I mentioned, like, structurally the knee, right, from an osseous standpoint, shouldn't really function like a hinge. Right, because think of it. Take two tubes, whatever it is. Take two tall, hopefully they're plastic. Take two water bottles, stack them on each other. That's kind of tippy, right? One of the ways that we can kind of prevent that tippiness, if you will, is through the structure here and here. These are the menisci, the medial and lateral menisci, or the meniscus. Right? These act like wedges, literally. Right? They help to prevent the knee from kind of, tipping from side to side. Right? They can definitely start to impact. They can definitely help to, or not. They tremendously help stabilize the knee. Right? If you ever heard of somebody, right? Oh, they have a torn meniscus and something like that. Again, that's where they have some sort of damage to the meniscus itself. Right now, whether it's worth getting surgically repaired, that's a huge, lecture for debate, or a huge, option up for debate. But regardless, that's what they're talking about. I mean, it's a torn meniscus or something like that. This right here, this is a structure they're actually talking about. Those two right there. This here, the ACL, the anterior cruciate ligament, this structure here, this ligament right here, the anterior cruciate ligament, the anterior and posterior, right? They come from where they are attached to on the tibia. So, for instance, this is the anterior part of the tibia. You are seeing the anterior part of the tibia right here. We'll draw an A on it. That's the anterior part. Posterior is in the back. The anterior cruciate ligament attaches kind of in the front face, on the very top of it, absolutely. Think of like the top, whatever. Think of like the top part of your head, the front of your head. That's where the anterior cruciate ligament would attach. The posterior cruciate ligament attaches in the posterior of the tibia. We'll look at that image in just a second, right? But before we get to that one, right? The anterior cruciate ligament, again, that attaches to the anterior portion of the tibia, specifically the anterior portion of the tibial plateau. Now that's going to prevent the tibia from sliding anteriorward, meaning that's going to prevent your leg from essentially sliding forward on the knee. Right. Some other ligaments that we see, right? The fibular collateral ligament or the lateral collateral ligament, this guy over here. Right. Here, the tibial collateral ligament, right? Or the medial collateral ligament, the MCL. Right. And these are further ways that the knee is going to help stabilize itself from kind of side to side. Now, right here where the fibular head is, right? I don't know why I drew the circle that big, but it did. The one thing about the fibula, right, the fibula bears for all intents and purposes, 0% of the body weight. Maybe like 0.5%, but it's probably less than that, if any. Its primary purpose is to provide an attachment site to help stabilize the knee, as well as the ankle. We'll look at that in a second. But to help stabilize the knee. Right, you can see. Right. The fibular collateral ligament, or the lateral collateral ligament, you see it comes up, attaches to the lateral aspect, or attaches to the lateral epicondyle, and comes all the way down and attaches to the fibular head. Right. Down here, the distal aspect, right, where we look at the ankle, we'll also look at how the lateral malleolus can help attach and form the ankle joint, be it through the tarsal bone or through the talus, which is one of the tarsals. Excuse me. Top down, anterior view. Right. If I were to take your leg and rip it off, right, and look at your tibia from the top down, here we can see a little better view of the menisci, how it kind of forms like this wedging, right? The lateral condyle of the femur sits right here. The medial condyle of the femur sits like right here. And these menisci literally act like a wedge. Right? As they act as that wedge, that prevents the femur and the tibia from tipping counter to each other. Now, when I had mentioned the ACL attaches to the anterior portion of the tibia, right? This is the anterior portion of the tibia, right? Anterior. Here's posterior. Here's posterior. The ACL would attach to the again, it's in the intertrochanteric groove of the not the intercondylar groove of the femur, excuse me. That you can't see here. We'll see that in a second. But the anterior cruciate ligament, you can see it comes all the way down and it extends on the anterior, or attaches to the anterior portion of the tibia, right in through here. Right, the PCL, same thing, posterior cruciate ligament. You can't see where it attaches itself to the femur, but on the tibia, you can see it attaches itself right here on the posterior aspect of the tibial plateau, right in through here. So whereas the anterior cruciate ligament prevented the tibia from sliding forward on the knee, right, one of the orthopedic tests, right, utilized to determine any sort of injury damage to the ACL is basically having a person lay on their back, their knees bent up, and then you kind of sit on the person's foot and you kind of just grab a hold of the leg and pull towards yourself. If there's quite a substantial amount of movement, then we're thinking, man, that's moving a lot more than it should. We should probably get the ACL assessed. PCL, same idea, right? The PCL does, whereas the ACL prevents anterior movement of the tibia, the PCL prevents posterior movement of the tibia. Okay, here, kind of cross section of the knee, you can see the amount of articular cartilage, right, all up and through here. All this articular cartilage, all up and through here, right? We see the suprapatellar bursa. Yeah, we've seen bursa. We saw the olecranon bursa on the elbow. We saw the subscapular bursa. We saw the subacromial bursa, right? We've seen this bursa throughout these different synovial joints we've talked about. And yeah, there's even the prepatellar bursa here, or infrapatellar bursa here. Yeah. Again, these bursa, they're meant to help prevent any sort of friction, any sort of adherence, any sort of irritation from building up on the tendons on the tendons or on the ligaments, because of how much these different tissues are sliding and gliding over top of one another. Here's another example of the menisci. Right, you can get a little better example of how it kind of acts like a wedge, literally acts like a wedge. Right here. Again, we see the articular cartilage just like before, lining the femoral condyles, articular cartilage lining the tibial plateau, again, the synovial cavity, and all of these things we talked about multiple times in the throughout the elbow joints. Here's just a little better image of kind of a gross or cadaveric model. This person definitely has a fair amount of thinning cartilage here on the femur. Right, it's really not that bad. Right, down through here definitely has a pretty thinned out amount of cartilage. Right, for sure. Right, you can see cartilage here on the back side of the posterior side of the patella, and that makes sense. Right, the patella, as you move, or as I bend, extend, and flex the knee. Right, the patella has to glide over top of this end of the femur. So there has to be articular cartilage there in order to prevent any sort of irritation, inflammation, etc. right? But running through all this articular cartilage, right? The menisci here. Right? Right, same idea. Right here is just where we kind of just put things back together, if you will, or if you're going to think about it that way. Right, we just simply put the patellar ligament right down through here. Right, the quadriceps tendon ligament, or the quadriceps femoris muscle ligament right here. Right, because that's the way that it works, where the quadriceps muscle attaches to the superior aspect of the patella, and then off of the inferior aspect of the patella, that's where the patellar ligament then extends downwards to attach to the tibial tuberosity. So here's a posterior view, right, of the knee. So this is where, whereas the image before we had looked at, kind of an interior, in deep view of the menisci, of the PCL, for instance, of the ACL. Here is where we see a large number of ligaments which stabilize the knee. How I mentioned, the knees structurally, from an osseous or a bony standpoint, shouldn't be a hinge joint, but it functions like one. And the reason why it does is because of the immense number of ligaments which support the knee. Right? So you can see, right from the standpoint, again, we pointed out already, right, the FCL, the fibular collateral ligament, or the lateral collateral ligament. We already pointed out the MCL here, or the tibial collateral ligament. Right. In here, right, this ligament which goes obliquely, right, or the oblique kind of adjacent or kind of diagonal, right? We see that's the oblique popliteal ligament. Same thing, extending down across to attach to the fibular head, something called the arcuate popliteal ligament. Right, so there's a huge number of ligaments which function to support the knee. Right, and there has to, because of the fact that it doesn't have as much osseous support or osseous structure. There has to be additional structural support to it. That's what can be achieved through the ligaments that are surrounding it. Again, that's just a good gross image, but I'm going to just take your time to feel it if you want to look at this. Okay. Another great gross image, right? Previous one really couldn't see too much, but right here, right, this is where we see, right, we can see the beautiful, right, medial condyle of the femur, lateral condyle of the femur. We see the meniscus here, right? Here's the lateral, here's the medial, here's the lateral. Right. The ACL, we can see it here. We can see it on the posterior aspect of the femur, attaching right here, and it comes down, and then we lose it. The reason why we lose it is because it goes to the anterior and attaches to the anterior part, again, to the tibial plateau, which is like the roof of the tibia. It attaches to the front of it, but it's still on the top. Right. The oblique ligament here, this had to be cut and reflected. Right, so therefore you can actually start to see the PCL here, and you can see the ACL here. So it's not generally down this far. It just had to be cut in order to be able to see underneath. So one of the things I want to kind of mention and talk about is just simply because of the sheer number of them which exist. Right? Or I say exist, or the sheer number of people who are getting them is, hip replacement or joint replacement or something called arthroplasty. It all depends on what joint it is, right? Sometimes there's full replacements, partial replacements. So depending on what the issue is, the severity of the arthritis, the severity of the degeneration, that all is going to dictate whether or not this person is going to receive some degree or some sort of joint replacement, right? So what they can do, right, is this kind of hash line through here and this hash line through here. What they can do is insert a titanium, actually I'll just go to the next image so you can see it, right? This shaft here, right, or this artificial head right here, this artificial acetabulum. What they can do is, literally, they can cut the femoral head off and then essentially drill down into the shaft of the femur. When they do that, they then insert this metal rod into the shaft and then hammer it in place. Like literally hammer it in place. Right. Up here, I grind out the damaged, the arthritic, the degenerated portion of the acetabulum, and again, using the same idea as far as this, I say industrial adhesive, the specific adhesive, it's almost like a bony cement that they utilize, inserts the acetabulum into the degenerated acetabulum, and now we have this new beautiful joint. Right, again, here's what we see. Right, a kind of a screw to help hold that acetabulum into that new acetabulum into place. Right here we see it. But this spike, as I mentioned, right, the femoral neck was cut off from here, so they cut the femoral neck off as well as what was, where the head was. So they have simply cut that off and drill a hole down in through the shaft. When they do that, they then pound the spike down into that opening. Right? That sounds painful. Yep, probably is if you weren't, if you were awake for this process. Right? But it really is. That there's a reason why people are as kind of sore as they are. Right? Now, with even a hip replacement, even after describing what I've described, it's not like they wait for days on end to get these people up and out of bed. I mean, they are up within within a few hours. Once they're back to their room. So even though there's an immense amount of kind of damage and reconstruction, reconstructing which is going on, the faster these people kind of get up. Now, if there's issues, if there's reasons why, if there's been some sort of what's the word? Some sort of something that went wrong with the surgery or some sort of issue as to the reason why you shouldn't move. Okay, that's one thing. But for people who complication, that's the word. It's a man. That's where I'm at. That's what kind of being secluded to your house does to you, is that you struggle finding the word complication. That's a simple word and I couldn't think of it. But anyways, right, as long as there's no complication from surgery or anything like that, they get these people up pretty darn quickly. Right, because they got to start that rehabilitation process quickly, right, because this is a new joint. Right, this is a new joint that's formed here. These people, right, who've had these people, everybody, we have learned to move. We've learned to walk. This hip learned to move the way that it did over the period of their life. Now all of a sudden, we cut it out. Jam the spike in there, all the muscles, the tendons, the ligaments, they all now have to kind of correspond, or our muscles and our brain has to relearn how to utilize the muscles with this particular joint. So that rehabilitation process needs to occur pretty rapidly. Same thing with the knee. Right, same thing with the knee. We can see here, right, depending on the severity of the degeneration, whereas right in through here, they can start to grind off and shave off the lateral and medial condyles. They don't shave them entirely off, but as far as the articular surface, and then right in through here, right, the surface of the tibial plateau, along with the corresponding hole in the cavity. You can see, same idea as with the femoral arthroplasty or the hip replacement. Same idea in that we can see this kind of spike, which is hammered down into that hole that was within the tibia. Right, we see the femoral component. Yeah, that's essentially more or less glued and bound into place on the femur. So look at this next. So remember, right here, again, with the tibia, with the tibial component, with the spike being driven down into the tibia, same idea, same concept as in the femur. Right. So as we've covered the joints, right, be thinking about how is it that these different joints can function. Think about why it is they function the way that they do. Our body has to be able to move in any number of directions, right? Certain joints permit that movement. Certain joints, right, and depending on the movement, that's why the joint is designed in the way that it is, right? There's a reason why, for instance, in the neck, you can achieve a huge amount of rotation. That's because the joints, right, those facet joints in the neck are very, very flat. They're almost horizontal in nature, right? Certain joints of the lumbar spine are much more kind of sagittally dimensioned, right? Those in the thoracic spine are much more coronally in dimension. So these different planes of, for instance, the facet joints throughout the spine, that's what permits the amount of movement. The reason the knee moves like it does has to do with the way that the joint is structured, right? The reason why the hip can perform circumduction, the reason why the finger can't perform circumduction has to do with the structure of the joint and the coinciding ligaments. So as you go through, right, as you're kind of studying for the exam, when you're thinking about, all right, what is it these different muscles can do? Or excuse me, what motion can these joints perform? Think about, all right, what muscle's involved with this, and where is it that that muscle actually attaches to? Because that can help you figure out, all right, what motion does this joint do? Does this joint perform adduction? Does this joint perform abduction? Or if you think about the deltoid, think of where the deltoid is. All right, it attaches to a few different places, but on the scapula and the clavicle. And it extends and it kind of falls over the side of the shoulder, and it attaches to the lateral aspect of the humerus, right, at the deltoid tuberosity. So just think about it. If the deltoid were to contract and shorten along that line of the muscle, what happens? All right, well, the arm lifts up as if I'm going to kind of, like if I'm like a bird or pretending to kind of fly. As my arm raises up away from my torso, oh, that's abduction, right? As my gastrocnemius muscle attaches to the medial and lateral condyle, it extends and it attaches to the calcaneus. So as the gastrocnemius muscle contracts and it shortens, it pulls on the calcaneus, which raises the calcaneus, which causes the foot or the ankle to perform plantar flexion. So think about where these attachments occur. Think about what muscles are involved. Think about the direction of the muscle, the grain of the muscle, and just envision or even stand up and perform that very movement on yourself. All right, and as I mentioned, if you have any questions, again, email, right, phone call, right, numbers on the syllabus. If you actually want to see and talk, talk one-on-one as far as not in person but through Zoom, by all means, right, shoot me an email. We can set up a Zoom session. As I mentioned, during class time. There's if you're unable to meet during class time as far as via Zoom, there's other class sections that I have on Tuesday, Wednesday, and Thursday as well. So there's definitely a time we can set up to go over these things, to meet, one-on-one through a Zoom session. As I mentioned, sharing screens through Zoom is incredibly easy, right? So even if you're like, oh, this part or this structure right here or this particular image, I don't get it, it's super easy to, share your screen. So if you have a question, please reach out.